Welcome to the presentation of Management of Obesity in Primary Care, a comparison of obesogenic drugs and their effectiveness in primary care by Karen Cross for Nursing 6999 on August 12, 2021. A patient presents to his primary care clinic and has a body mass index in the obese category. The patient has been actively trying to lose weight over the last 6 months, has been working with a nutritional specialist, and has been monitoring his caloric intake, only to have lost 10 of the 80 pounds he needs to be considered healthy. As nurse practitioner, what is the best practice? The CDC defines obesity as an individual that is carrying more weight than what is considered healthy for a given height. This is translated as a body mass index and is calculated by measuring the height and comparing the weight of the patient and then translating these results to a standard. The patient is then categorized into 4 categories: underweight, healthy weight, overweight, and obese. Within the obese category, there are then 3 classes of obesity. Class 1 is a BMI of 30 to 34 or below. Class 2 is a BMI of 35 to less than 40. And Class 3 is a BMI of greater than 40. Class 3 obesity is further defined as morbid obesity and carries the largest percentage of comorbid conditions. Medical professionals are strongly encouraged not to solely depend on BMI in diagnosis of obesity. It is also important to measure skin fold as well as waist to hip ratio. Why should we care about obesity? It's because obesity has become an epidemic. Since the 1980s, the prevalence of obesity has doubled, and not just in America. Today, 1/3 of the world's population has a diagnosis of either being overweight or obese. The cost associated with obesity is nearly $147 billion. If this trend continues, 57.8% of the world's population could be considered overweight or obese by the year 2030. But cost should not be the sole reason why we should care. It's because obesity is also known to cause many complications, including increased cardiovascular risk factors, symptomatic osteoarthritis, hypertension, insulin resistance, kidney disease, sleep apnea, coronary artery disease, and possibly cancer. Initial management. Management of obesity should always begin with lifestyle modifications. This includes diet, exercise, and counseling. These interventions should always continue through therapy until successful weight management has been achieved. This is when a referral to a nutritional specialist is highly recommended to improve patient outcomes. As future providers, we cannot squeeze in the amount of information that is needed in a 20-minute appointment. Therefore, it is important to refer them to a specialist. Well, this article will discuss the different pharmacological modalities that will help patients reach their weight loss goals. This project will seek to find among nurse practitioners caring for obese patients within a primary care setting, does a nurse practitioner manage obesogenic medication therapy, education, and prescription practice compared to no education and prescription decrease BMI over a 1-year time frame. Candidates that could be potential for participants for the study include patients who are considered overweight or obese. These are candidates who have attempted to lose weight but have not lost more than 5% of their goal weight within a 3 to 6 month window. Candidates with comorbid conditions associated with obesity are also included in this study. Medications. Current guidelines for prescribing medications for obesity recommend only using a single agent. But in my research through the guidelines, the authors did not identify a specific medication, only provider and patient preferences and what the insurance might cover. The FDA has approved the following medications in the treatment of obesity: semaglutide, liraglutide, orlistat, phentermine and topiramate, and naltrexone and bupropion. Semaglutide. Semaglutide is a GLP-1 receptor agonist which has been used effectively in the treatment of obesity. And this is independent of a diagnosis of diabetes. In these particular studies, patients were either given a once-weekly dose of semaglutide at 2.4 milligrams via an injection or a placebo. Patients given the dose of semaglutide lost an average of 15.3 kilograms versus the placebo at 2.6 kilograms. Liraglutide. Liraglutide is another GLP-1 receptor agonist used for weight loss. In a 56-week randomized trial, patients were either given a 3 milligram daily injection or a placebo. Participants on the medication saw an average of 8.0 kilogram weight loss compared to a 2.6 kilogram weight loss with the placebo. The other interesting finding was that there was also a delay in onset of diabetes type 2. Orlistat is a reversible active site inhibitor that works on gastrointestinal lipases, which then prevents the absorption of dietary fat. Through the many studies completed with this medication, patients lost an average of 5 to 10 kilograms versus a 3 to 6 kilogram weight loss with the placebo. Further benefit was seen in the improvement with cardiovascular symptoms or risk factors. Hemoglobin A1C was also reduced, and then serum lipid values also were reduced. Phentermine and topiramate. This is identified as both an amphetamine and an anti-seizure medication used in combination since the year 2012. Phentermine, however, has been used since the late 1950s, but was found to be highly addictive. Stigma associated with this drug continues to cause providers to prevent usage of this medication because of the extreme caution with drug addiction, despite its effectiveness. In the studies that were reviewed, this medication was shown to elicit an 8 to 10 kilogram weight loss compared to a 1.4 kilogram weight loss with the placebo. Bupropion and naltrexone. Bupropion is an aminoketone with an antidepressant activity, and naltrexone is a neuroxymorphone derivative, which reverses the effects of opioids. It is the final medication approved by the FDA for use in weight loss. While this is not the first-line choice, and it usually requires the presence of at least one weight-related comorbidity, weight loss is not as successful as on other medications. The caveat to this is that this medication is very good for patients who need to lose weight as well as want to quit smoking. In the review of randomized trials, patients demonstrated a 5 to 6% weight loss while on this medication, while on the placebo, the weight loss was at a 1.3%. But the side effect profiles of these medications, usually involving GI system and causing gastric discomfort, change in bowel patterns, nausea to start, compliance with these medications is difficult to attain despite successful weight loss. This research will also help to identify a nurse practitioner-driven project to introduce education with the goal to increase compliance on medication usage. This is compared to lack of education or formal communication following the initial prescription. The data to be collected for future studies, both at the onset of the study and every 3 months for a year, include height, weight, and a hemoglobin A1C. All of this information will be calculated in an independent t-test, which we'll use to compare pre- and post-intervention results. Also, to minimize any type of variation in communication, we will utilize the 6A method, which was recently founded to improve patient adherence. The 6A's include asking the patient about a medication adherence, assessing medication adherence, assisting the patient with medication regimen while utilizing available resources, anticipating the needs of the patient, assurance of the efficacy of the chosen therapy, and lastly, avoiding blame when the patient is non-compliant. In conclusion, the research has shown that effective weight loss can be achieved through lifestyle modifications, but patients with comorbid risk factors or those who fail to meet the minimum goal for weight loss in a 3 to 6 month period may benefit from pharmaceutical interventions. Despite medication used, there is still a considerable benefit from communication between the provider and the patient to ensure compliance and efficacy of the medication. Through communication, not only is the nurse practitioner fostering a therapeutic relationship with their patient, she or he is also advocating for the patient's success. While this particular article was about weight loss, the theory could still hold true for any disease process in pharmacologic intervention. Communication is key. I came across this quote, which I love. It is words to practice by. No matter what job you have in life, your success will be determined 5% by your academic credentials, 15% by your professional experiences, and 80% by your communication skills. Communication is key in the future practices of all nurse practitioners. Thank you so much for listening to this presentation and have a wonderful day.